people who don't know that, it's like football, but it's a sort of a squashed ball and you throw it around the field.
More violent.
And this guy's very fit. He trains high-intensity training for an hour a night, plays an 80-minute match at the weekend. And last year, he unfortunately, during a match, went in for a jackal, that's a technical phrase, and avulsed his hamstring completely. So he went for an MRI scan, saw his doctor, and his doctor picked up a murmur. And subsequent to that, he was sent for an echocardiogram, of which you can see his transthoracic echo. And he was diagnosed with a type 1 Sievers bicuspid valve, so a classic right and left fusion. And the echo report said moderate aortic regurgitation, eccentric, so difficult to quantify, but he does have dilated left and right ventricles with normal function, diastolic and systolic function. So his cavity size didn't appear absolutely enormous, but he was referred on to the sports cardiology clinic, and this is his sort of initial investigations at the sports cardiology clinic. His ECG on the left-hand side essentially is normal, and on the right-hand side is his CPEX. Now, I don't know how many of you necessarily know very much about CPEX, but essentially, it shows that he is fit because he managed 174% of his predicted work, so for his watts. But he said to me he was a bit disappointed by this. He got his peak VO2 max at 41, which for a guy who does high-intensity training is maybe not as impressive as we thought it would be. But my colleague who does the sports cardiology clinic is also a cardiac MRI expert, and he decided, well, I'm a bit worried about this echo because it says the cavity's big and he's got aortic regurgitation, which is eccentric. I'm going to send him for an MRI scan because it's very useful in particular for assessing the quantification of the volumes and the mass, remodeling. We do this for a lot of our sports patients, but also it's extremely helpful in quantifying eccentric aortic regurgitation. So you thought I'm going to do everything in one sitting and get all the information I need to see if I want to worry about it. So you can see here on the left-hand side is just his volumetric assessments for his left ventricle, and on the right-hand side he's got his late gadolinium enhancement images. And there was no scar at all. His T1 mapping was normal, his T2 mapping was normal, his ECV was 26%, so again normal. But his cavity size was corrected to his body surface area, 150 mils per metre squared, which is hitting the severe range of dilated left ventricular size. But just to add a little bit of complication to that, his right ventricle, when indexed to body surface area, was also 150 mils indexed. So, it's not moving on again. There we go. Some further advanced analysis here. You can see his strain assessment. So on the echocardiogram, they didn't estimate his global longitudinal strain. But here you can see that his GLS was absolutely normal with the bullseye on the left-hand side. The strain patterns looked normal. It was minus 19%. His circumferential strain was also normal. So he's got two ventricles which are dilated, a bicuspid aortic valve which is regurgitant, but normal function. For the quantification of his aortic regurgitation, you can see on the right-hand side the degree of AR. His percentage regurgitant fraction was 30%, but his actual volume was 50 mils, or in the 50 mil range, so quite significant because his stroke volume was actually very, very high. It was 150 mils. So here you've got a guy who's hitting the severe range for his regurgitant volume, but his regurgitant fraction is actually quite, well, in the moderate range because of the extremely large stroke volume. So what are you going to do now? He's completely asymptomatic, by the way, still playing high-level sport. So we've got a few options. We're going to do this hands raised because it's the easiest way of doing it. Okay, who's going to watch and wait with this chap? Okay, so a few people. Who's going to send this patient for surgery? Get this valve replaced? Okay, no one. One person, sorry. Who's going to send this patient for consideration of a Ross procedure? One person, thank you, Nick. Okay, who's going to send this patient for a valve sparing repair? There's lots of you who aren't going to do anything. Who's going to get another test? Yeah, well, it's always another test, isn't it? When you can't decide. It's an imaging meeting, but also when you can't decide what to do with the information you've got, you get another test. Okay. Also, he's a lawyer with 2 children. So, here's your next test. So he was sent for a transesophageal echocardiogram, and this is where I meet him. And this is the twist to the plot. I get a text the day before my TOE list from somebody that I play rugby with, and he says, "Tim, your last name's Fairbairn, isn't it?" Yes. "I think I'm coming for a procedure by you tomorrow." I said, "Oh, right, okay." So this is my next door neighbour. So here we are. This is his TOE. So you can see it shows very much what the transthoracic echocardiogram does. He's got a bicuspid aortic valve, type 1, with a prolapse, which you can see very clearly of his fused cusp. with eccentric aortic regurgitation. His volumes by 3D analysis did show only a moderately dilated LV on the transesophageal echocardiogram. And you'll be delighted to know that all of the measurements were extremely clear. So here is his 3D EROA, which was 0.23, which is in the moderate range. But we have a slight problem because his volume for regurgitant volume was 86 mils, and his fraction was actually 50%. So now what do we do? Well, it wasn't just for assessment of the degree of aortic regurgitation that he came for his TOE. He came to see whether or not the valve was repairable, because my physician colleague felt that was an extremely important question and anything to discuss with this patient. And therefore, we need to know several things from this TOE and also any other imaging that we've performed. So the first was the likelihood of successful repair, the type of the valve, but we need to know certain parameters. So we need to know the effective height, the geometric height, the coaptation height, and the annulus size, and also the sinus and sinotubular junction. So I didn't know that there was going to be an abstract on this earlier. It's just fortuitous. So you've all been briefed about this, but these are the measurements that we need to look at. And you can do these on TOE, and we do them on a regular basis. And here you can see a nice graphic from a paper demonstrating exactly how you do it, how you realign the crosshairs on the 3D assessment and get these measurements, which I did. But this patient also had not just one test requested by my colleague, but two, and he was having a CT scan on the same day. And the reason for this was principally to assess his coronary arteries prior to any consideration for surgery, but also for consideration of a Ross procedure. So we do this routinely for our patients being considered for Ross. And one of the advantages of having this multimodality imaging is that we can do the measurements on the CT scan equally as well as we can do it on the transesophageal echocardiogram. In actual fact, I find it a bit easier than doing it on the TOE, and our surgeons find it slightly more reproducible and more closer associated with the Hager measurement that they take intraoperatively, which is the main measure of success for these procedures. So you can see on the left-hand side the TOE image, and on the right you can see the CT scan for the aligning up in diastole, end diastole, for the tips of the leaflets, and then measuring in particular here the geometric height. So here I've just cross-cut through the different cusps and measured the geometric height, so the length from the base of the annulus up to the tip of the leaflet. And you can see on the left-hand side, the left coronary cusp very clearly with its prolapse. So it really is a very nice and clear demonstration of what this gentleman's anatomy was, but also what the problem was. So we've done the geometric height for both the left, the right, and the nom. We then also need to know the other measurements, which is the effective height. So here you can see on the left-hand side the measurement using the TOE scan, and on the right-hand side the CT scan. Of course, you're all going to find the CT scan a lot clearer because that's what you're used to. But I do agree it is actually a bit easier to do these measurements, not just from a practical perspective, but from an image clarity perspective. And then the final thing that you need to know is the aortic annular measurements. And it was mentioned earlier, this should be done in systole. It can be done in diastole as well, but preferentially, if you can do it in systole, it's the best thing. And you need to know whether this is dilated, so above 29 millimeters or not, because this is important for the surgeon to consider in terms of what they're going to be doing once they go in and try and tackle this valve for repair. And then the final thing we assess in these patients, so we do a sort of a 20 to 80% phase scan for patients who are considered for Ross. And here you can see that we can also measure the pulmonary valve annulus. Unfortunately, this scan was not perfect because the injector stopped halfway through because of an air occlusion, I think. But in actual fact, it was sufficient for us to be able to look at his annulus. This is probably the most challenging thing. I actually find this easier on MRI, but again, we've looked at this internally, and the measurements on CT have a very close correlation with intrasurgical measurements, particularly if you do it at the almost subvalvular level. So, the next thing that you need to assess is this commissural orientation. It's extremely important to know whether the valve is asymmetric or symmetric, so whether it's less than or 160 degrees. And you can see on the left-hand side the measurement using TOE, and on the right-hand side the measurement using CT. It's extremely easy to do, extremely reproducible and highly accurate. And I got 162 on the CT and 167 on the TOE, so that's pretty good. And then next, we're going to ask another question. So, I'm hoping everybody's paid attention to this, but also to the talk before. What is the feature that predicts repair failure? So, who's going to go for bicuspid valve? Is that a prediction as to whether or not he's likely to have a successful repair? Okay, no one. How about annulus? Annulus less than 27 millimeters. No. Asymmetric commissural orientation? 1. Okay. 2, 3. Geometric height of 20 millimeters or more? No. All of the above. few people will go for it. Okay, maybe I didn't explain it clearly enough. But essentially, asymmetric commissurial orientation is the correct answer. Thank you. So, understanding the phenotype of the aortic regurgitation is extremely important. And as you can see, on using this multimodality approach, using a cardiac MRI scan, CT, and the TOE, you can really assess this in greater detail. And obviously, our gentleman had a type 2 Alcari, so he had a prolapse of his fused cusp. And that's important because this can help predict whether or not the patient's going to have a successful repair. But knowing that this patient has a type 2, and then we need to understand which features are going to predict whether this patient is likely to have a successful repair. So it used to be thought that whether you had a bicuspid valve did predict this, but in actual fact it doesn't. It's more the measurements that you're doing is aligned with this, which will predict whether or not the patient's likely to have a successful repair. So that asymmetrical versus symmetrical orientation, whether the patient has an effective height which is sufficient, so greater than or less than 10 millimeters, and what the geometric height is as well. This varies between whether it's a tricuspid valve or a bicuspid valve. And all of these features that you measure will then help the surgeon have a decision about whether or not they can go in and repair this valve. And if they go in and repair this valve and they tackle these things such as the commissurial orientation, then the success in terms of longevity is extremely good. So here is some 10-year data showing that patients are extremely sort of disease-free in terms of coming back for a reoperation, likelihood of having subsequent aortic regurgitation, and even mortality. So we quote that about a 10-year success of 95% of these patients not coming back and having another operation, which is really very good. So as one of my colleagues said to me, that this is all wonderful, but in reality, Tim, you are the middleman. You just take the pictures, and they are correct. So I'd just like to thank my aortic colleagues who do these procedures. Last week we did 3 valve-sparing routes on the same day for the first time. So they really are sort of heroes. And in this gentleman's case, it's much easier to have a discussion with him about going on and having a repair, because his risk of having subsequent problems to that is extremely low. So it's a much easier patient-physician discussion to have in terms of operative risks and benefit. Thank you very much.
This is, we actually have a fair bit of time for dialogue and discussion through this session, so welcome anyone to come to the podium if they have any questions. I think this was a fascinating case, and obviously your experience is much broader than ours. One of the questions I have as it relates to bicuspid valve assessment, to what extent are your patients undergoing CT routinely, and to what extent is someone who does TOE, as you say, I don't know, instead of TE.
TE.
Are you finding that CT will complement your echocardiographic assessment in ascertaining the morphology and the diagnosis of bicuspid valve disease?
So the CT can really help with the morphology, even above TOE sometimes. In particular, deciding whether it's a type 1 or a type 0. Sometimes with the commissurial orientation, as I showed, I think it's really beneficial. So we now routinely do it in all of our patients, and that's because we know that most of them are young and they're going to end up going for surgery, and we're looking at the coronaries, and we want to make the most of the information that we're going to get. So all of our patients now will get a CT scan, as well as probably a TOE, and most of them will get a cardiac MRI as well. And part of that is the bit I mentioned about the ROS. The backup for repair when the surgeon discusses with the patient is going to be, I'm going to repair your valve. It's going to be successful, but there is a small percentage chance, maybe 1 to 2%, that we will not be able to do it intraoperatively, or something will go wrong. And my backup to that is, I don't want to put a mechanical valve in you because the outcomes are poor. Sure. I'm going to put a ROS. I'm going to do a ROS. And they want to know about the mismatch between the pulmonary valve annulus, which we can see is often quite large, and the aortic valve annulus. And the MRI scan we find is extremely helpful for doing that. But the CT as well is extremely useful in predicting that. But we've looked at different measurements as to where doing the pulmonary annulus is. And that is mostly difficult in terms of reproducibility, inter-observer, etc. So that's a bit more of a challenge, but it's extremely helpful.
Ashraf, please.
I think we have to look at the guidelines, mainly at the European and the American guidelines regarding the replacement or repair of aortic valve in patients with aortic valve regurgitation. We still have we need more knowledge. What would you recommend based on regurgitant fraction? At which level you would perform a replacement or repair of the aortic valve.
So I haven't shown it, but the reason why this guy has such a low regurgitant fraction is because of his enormous stroke volume, but also the reason why he has such a large regurgitant volume is because his average heart rate is 45. So he's got this enormous time for diastole for filling his left ventricle. And I think the guidelines are helpful, but you have to know your patient. So this is a 35-year-old lawyer. He's got 2 kids. He's got critical illness and life coverage, which pays out if he's diagnosed as needing a repair. And he is actually coming to me saying, I would like to be considered if this is possible for a successful repair. So, I'm not saying that that's you're completely directed by the patient, but you need to give the patient the information as to what the likelihood of the success is, and then have that informed discussion with them. In this case, I think it's particularly difficult. I was on the fence in terms of watching and waiting, and doing annual MRI scans to look for any changes in his, whether you call it adverse remodeling, because his right ventricle is the same size as his left ventricle indexed. And whilst he's not got a massive score in terms of his CPEX, he's very, very fit. And 150 indexed for our sports cardiologist was too uncomfortable. We have a lot of professional athletes, and normally they will index up to about 130, 135. It's quite unusual to be hitting 150, and that's where he's concerned. So he was pushing much more for an early intervention. But these are, as I said, nuanced discussions that you have to involve the surgeon, the patient, the sports cardiologist, the imaging cardiologist like myself, who's not a sports expert, and try and convey the sort of the information that you can do to the patient for them in the end to make their own decisions to what they want to do.
Did you explore mapping as far as T1 mapping, ventricular dysfunction or ventricular injury damage related to the AI, and does that play a role at all?
Yeah, so that's one of the reasons that the MRI was requested. So it was to look for if he had an elevated ECV, which he doesn't. It was normal. It's 26%. In particular, rather than the T1, I think we think the ECV is probably slightly more useful in these instances. If he had any evidence of fibrosis, I think probably again you'd be leaning more towards going ahead and doing something. And that's where this complementary aspect of getting this multimodality imaging is. I mean, I criticise people for requesting too many tests normally, but I think in these complex cases, in actual fact, it's actually probably the right thing to do, because you need that information to then be able to decide exactly what the risk-benefit ratio is.
Well, thank you so much. Oh, please.
Thanks for this presentation. My question about if you have a question with a renal impairment and you want to have these measurements, especially for the annulus, can you do it with a native scan without contrast?
Oh, well, you could do it with an MRI scan, not with the CT.
In case of not availability.
In case of
when not available or not.
So then I do it on the 3D TOE. You can get pulmonary measurements, and 3D TOE is very, as long as it's decent quality, it's extremely reproducible and accurate. I guess the main issue is inter-observer reproducibility with the TOE. We're a lot more accurate in terms of inter-observer reproducibility with MRI and CT for these measurements, but you can do it very well on 3D TOE. But for me, the best modality is in reality the CT for all of these dimensions.
Okay, thank you.
Excellent. Thank you so much for that great case. Now we'll welcome for the second talk, Dr. I'm going to pronounce your name properly. It's always easier to just say it by first name. But Marco Guglielmo. Guglielmo.
Yeah.
Okay. Either way, that's my best Sicilian. But
Thanks,
either way,
Jonathon.
it's wonderful, Marco, to have you joining us. I've known Marco for many years from his time back in Milan. Now he'll share us some interesting thoughts from a case from Utrecht.
Thank you very much for the introduction, Jonathon. Good afternoon, everyone. I'm imaging cardiologist at the UMC Utrecht. This one, okay. Yep. So I'm gonna present a case of a 64 years old male, a patient with a history of non-Hodgkin lymphoma, and he was treated with radiotherapy and chemotherapy. and he developed severe aortic stenosis. And in 2016, he was treated with transcatheter aortic valve implantation. And he got also a pacemaker related to the implantation as a complication, and the follow-up was quite good, but in 2023 he came with a dyspnea, and we made the diagnosis of a severe mitral stenosis, a calcific mitral stenosis. And we discussed this case with our heart team, and the surgeons decided the patient was not operable with an open heart surgery due to very high risk, and it was discussed for treatment with a transcatheter mitral valve replacement, which is a relatively new therapy, catheter-based, where we replace the mitral valve, and it's possible to do that transapical, it's possible to do that transeptal or even transatrial, and it's indicated in different condition in severe mitral regurgitation when the patient is not operable or we cannot perform a TER. And it's indicated in cases of failure of bioprothesis or failure of a ring, or in patient with a severe mitral stenosis due or combination with regurgitation due presence of a mitral annulus calcification. So there are different types of devices that can be used, but for mitral annulus calcification, often we use the Edward Sapiens, so a balloon expandable valve that can be placed also transeptal. It's cool, but it's also dangerous, because we have to take into account lots of possible risk factors, because this can happen. So left ventricular outflow tract obstruction with we see here that the valve touches basically during the systole and also during the diastole, the septum. And so we use the CT to study good anatomy of the patient. It's important to acquire correctly the CT. So it's important to acquire the entire cardiac cycle, and to reconstruct that, it's recommended every 5% of the RR interval. We can do a biphasic injection or triphasic if we want to also study the interatrial septum and look very good also the right side of the heart. And of course, the approach in these patients is always multimodal. We start with the echo that we see here. We see severe mitral stenosis, very calcific, with a calcification of the leaflet and of the annulus, and there is a combination of mitral stenosis and mitral regurgitation. So we see here a ventricle which has normal dimension, and this is important because small ventricles is associated with a higher risk of obstruction after the positioning of the catheter, of the mitral valve. And also it's important to assess the dimension of the septum with the echo, but also we can do that with the CT. Here we have 30 millimeter. So if we have a very thick septum, there is a higher risk of obstruction. And then we assess the length of the leaflets. So if we have a length of the leaflet, especially of the anterior leaflet, which is more than 25 millimeters, then higher risk of obstruction. And we can measure with CT also the angle between the plane of the left ventricular outflow tract and the plane of the mitral annulus. So if this angle is very narrow, is less than 120 degrees, then the risk of obstruction is higher. In this case, we have 131. And then we have to size our prothesis, so it's important to measure correctly the annulus. The annulus is a complex structure, so we know it's a saddle-shaped structure, and it's not a still structure, but it's always in movement. So we have a dimension of the annulus that is bigger in diastole than in systole usually. And it's a structure that is in strict contact with the aortic valve and also with the left circ. So we could measure it simply using our MPR. So we could basically find the minimum diameter of the annulus, the anteroposterior, so basically a 3 chambers view. And then we could mimic a bicommissural view with the CT to obtain the biggest diameter. And then we could get our unfaced view, so measuring basically the area, the perimeter, and here we have again a maximum and minimum diameter. But it's not so easy actually, because the mitral annulus is very complex, as a complex structure. If we do like that, we could measure that not correctly. So we could use software like the Circle software, which are able to measure that properly. So with the Circle, we can get our 5 key metrics for valve reporting. So first, for the annulus, first metric, so we have to identify the mitral valve. We have to identify the tip of the leaflet of the mitral valve, and then after that we have to put some points, 16 points in total, at the hinge point where the leaflets attach to the muscles. And then we get basically this image, because there is an interpolation of the points, and then we get a perimeter, we get area of the annulus, and we get the intercommissural and the intertrigonal diameter and the septolateral diameter. We can get all the dimension of the annulus, or we can cut that at the level of the trigons. Of course, when we have a classification of the annulus, is quite tricky, it's quite difficult, but if we use this method and then we try to adjust that, trying to follow the inner edge of the annulus, we could get a measure that is accurate. So in this case, we have lots of calcium at the level of the posterior annulus. We have also classification at the level of the muscle. And with Circle, we can also assess the volume of the calcium. And it's quite important to know the characteristics of the calcium, because if we don't have enough dense calcium, we cannot anchor properly our prothesis. So there is this core of mitral annulus classification that was published by an expert consensus, and basically on the basis of calcium thickness distribution, if the distribution of the calcium is symmetrical or not symmetrical, and is circular or not, the presence of classification at the level of the trigons, and involvement of the leaflet, we can get a score to predict the possibility to implant transcatheter mitral valve to avoid embolization, basically, and the risk of paravalvular leaks. So with Circle, it's possible then to simulate the implantation of the valve. So there is a possibility to simulate a specific valve, for example, a tendine valve, or if we have to try to implant Sapiens valve, then we can use just a cylinder. And we can simulate the landing zone. Of course, it's quite difficult to know where exactly we're going to put the valve during the procedure. But basically what we do is putting the offset in a way that the valve is more ventricular than atrial, about 80% ventricular and 20% atrial. Because the valve tends more to embolize in the atrium than in the ventricle, also because here we have for the Sapiens the skirt, and we can put that at this level trying to avoid then paravalvular leaks. Then we trace the left ventricular outflow tract, and we identify the neo-LVOT, which is new anatomical entity, basically due to the fact that the anterior leaflet of the mitral valve is displaced due to the presence of this new valve, and the LVOT is elongated, is narrow. And it's possible then to measure exactly the neo-LVOT at the level where it's narrower. So in this case, we have a neo-LVOT area of 2.02 centimeters square. So question for you. So what the neo-LVOT area measurement best predicts LVOT obstruction? It's less than 5 centimeters square, less than 1.7, less than 3, or more than 2 centimeters square. Who says, yeah, we can raise your hand. 1.7, yeah.
Probably varies based on the device and the procedure.
Yeah, it's quite yeah. It's variable, of course. There are different cutoff, also different studies. Less than 2, let's say it's safe. We can also predict the best fluoroscopic projection with Circle. Then it's possible basically to obtain different angles rotating this fluoroscopic simulation, and usually we use this compromise view. There is a view between a setolateral view where we are parallel to the anteroposterior diameter of the mitral annulus, and the intertrigonal view. And if we perform transapical implantation, so it's possible also to simulate the transapical puncture and the fluoroscopic projection of the transapical puncture. So basically, when we use the software, we have these two lines. One line connected the center of the valve to the true apex, and then we have another line that allows the implantation of the valve coaxial, and then indicates where we should perform our puncture for the transapical puncture. So we can then use the structured report where we can put lots of information. So dimension of the left ventricle, interventricular septum, the length of the mitral leaflets, and the angle of aortic annulus, mitral annulus, the dimension of the annulus, area, perimeter, and all the diameters, the dimension of the neo-LVOT, and then also we can comment about the fluoroscopic best projection that I choose always together with the interventional cardiologist, and transapical approach assessment if needed. So this is our patient. Here we have a intraprocedural echo. Here we see the implantation of a sapien valve, and this is the nice result with the 3D echo. And with color Doppler, we see no stenosis, we see no regurgitation. Here we see the nice images of the 3D echo. And this is the CT post implantation. So we see here the previous TAVI, and here our transcatheter mitral valve nicely implanted. So I then used basically the data set of this case to try the new core CT function of circle. So basically using a deep learning, it's possible to calculate the volume and function of both ventricle and also the mass of the left ventricle in just a few seconds, because there is an automatic recognition of the 3D data set and the borders of the ventricle, the endocardium and the epicardium also of the left ventricle. So with this overlay, then it's possible to see if there are discrepancies in our evaluation and that of the software, and it's possible to correct that. And this is the 3D rendering with the function of both ventricle. Of course, it was not useful in this case, but in cases where, for example, we have an acoustic window of the echo that is not sufficient, we cannot perform, for example, MRI, then we can use this kind of software. So here the results, and this is of course much less time consuming than before, because before we had basically to use our data set, and we have to choose our slice thickness of the short axis view, and then try to simulate the cardiac MRI assessment, and we had then to trace manually also the endocardium and the epicardium of the left ventricle, endocardium of the right ventricle. It was also possible to do an assessment with the 4 chambers and 2 chambers view, a biplanar assessment. But now with this deep learning assessment, it's less time consuming. And finally, it's possible also with this new software to obtain the strain automatically. So it's very fast, it's not less consuming like before. So it's possible to get circumferential strain, radial strain of the left ventricle, longitudinal strain of the left ventricle. And for the right ventricle, we get the longitudinal strain and the circumferential strain. Thank you very much for your attention.
Great. Thank you for that excellent case. We have a few minutes for questions, if there are any. To what extent are people in the audience using, or are there proceduralists doing advanced leaflet modification for either, valve and ring, or valve as far as Lampoon or Sesame, or any electrocautery surgeries? Any experience in the room? All right. There being a lot. The one pearl I would add to Marco's excellent presentation, we talk about the neo-LVOT, and when we originally proposed that now a decade ago, we sort of assumed maximum or a certain geometry of the post-implant device. And I think one of the things we've learned with looking at some of these novel transcatheter mitral valve devices is that they all don't expand to their full extent, right? If you look at an Intrepid device, they're constrained in the A2 to P2 dimension. And so the pre-implant neo-LVOT is much more conservative than the post-implant. So I think your imaging, looking at pre and post, is so helpful to understand not only what you're predicting, but actually how your predictions correlate with the actual reality. So Either way, we'll take another 5 minutes. Let me thank my colleagues for excellent cases. I really had very little to do, which is best for everyone. I want to thank Circle as well for the sponsorship of this session, and look forward to the debates. Thank you so much.